Breathing better, congestive heart failure. There are so many causes of shortness of breath, and what I think is happening is, unfortunately or fortunately, the leading cause of death for many people will be congestive heart failure. That's unfortunate. That's the bad news. The good news is, because we've done such a great job of preventing heart attacks and strokes, treating people with chronic renal disease with dialysis, better people not smoking as much. We are living longer, but the quality of life towards the end is suffering because the heart can't pump properly. And we're going to explore this quite a bit with Monica and her team. And let's have the next slide, please. So welcome, everybody, and so much to talk about. So I'm going to let Monica take over right now.
Thank you, Doctor. So I'm quite excited as well to discuss today. So we're going to go over what is congestive heart failure and talk about the structural issue that happens with the heart, because I personally find the heart very fascinating, and understanding things behind it will help us understand how we diagnose it, and then how can we manage and treat it. And then we're going to get into the diagnosis and the management. So to start off, we have a quick icebreaker activity. So we have this hypothetical patient here. Their name is Stethoscope. It's a 63-year-old male, and they come into the clinic and they have this history of 2 heart attacks. They suffer from hypertension, and they're also managing type 2 diabetes. And they come in and they say that they've been having shortness of breath for the past 4 months. They've noticed that they're more fatigued now, and they did this special blood test called BNP, and the results were 600 picograms per milliliter. Now, if you don't know what that means yet, we will get into that later on in the evening. And then we measure their blood pressure in clinic, and we find out that it's 98/82, and their heart rate is quite quick, 110 beats per minute. So looking at a few extra tests and doing a few more scans, we can, with the expertise of the doctor, the diagnosis could potentially be, any ideas? It's also the topic of tonight. It would be congestive heart failure. And once that diagnosis is made, there's lots of things to explore in terms of treatment and management.
Go back one slide for a second. So when I first started, before I first started practice, when people had a heart attack, they were usually put in a back room, quiet environment in a hospital. They were in bed rest for about 30 days, and then you got up, you were deconditioned, and if you survived all that, you went home. You didn't have any therapy for heart attacks. Now when you come for a heart attack, it's a medical emergency. Your vessel will be opened with an angioplasty catheter as quickly as possible, because time is muscle. And because we have better therapies for high blood pressure, President Roosevelt, a famous president of the United States, died with a blood pressure of over 200 initially. And so he had problems with stroke. In fact, if President Roosevelt's blood pressure was lower, Russia would be a much smaller country today, because what happened was that Roosevelt was getting confused. He had something called hypertensive encephalopathy. I mean, his brain wasn't working because blood pressure was damaging his brain. And the Russians knew about that, and they held meetings at nighttime when Roosevelt was more confused. So it's too bad we didn't have effective therapy back then, and he died of a bleed inside of his head. Type 2 diabetes has been around for a long time, and now we have very effective therapies right now. And because we treat heart attacks better, we treat our risk factors better, we're now extending life, and the heart's wearing out with congestive heart failure. And we'll learn what BNP stands for shortly, and it's really a new marker that really adds a lot to people's management. The only problem with that marker is it's not covered by the government at this point in time, but you can decide if it's worth the $75 for yourself to measure. And I think in some circumstances it's a game changer. Having a low blood pressure and a high heart rate is important. And right now with telemedicine is that if you don't know your blood pressure, your heart rate, or you don't know your weight, you're giving yourself a lot of disservice right now. So if you walk away with a message, is that you gotta measure your vital signs. If you're going to wait for Shoppers Drug Mart to open and measure the blood pressure there, it's a bad choice, because home blood pressure monitoring is important. And what we learned from pandemics and other infections is you deserve to have your own blood pressure machine. You deserve to have your own scale, and you deserve to know more information and take better care of yourself. So we need to actually treat and prevent congestive heart failure better. Next slide, please. Go ahead there, Monica.
Thank you. Yeah, and I think also, building on what Dr. Kern, you said, we have better treatment and management. So the term congestive heart failure can sound scary at first, but with all these resources, it's good to actually be talking about it and learning about it. So do you ever find yourself short of breath at rest, short of breath during physical activity? Are you waking up at night catching your breath? So as you can see here, shortness of breath is quite a big symptom to look out for. So think back about, in your daily lives, are you experiencing this, or when does it happen? Well, that's why we're here to talk about it today. And we do have a few YouTube videos about it. So we've done a CHF series on YouTube. It's 3 parts on Dr. Kernew's channel that you can check out. We also had a seminar discussing managing congestive heart failure and understanding your echo results. That's quite important, because echo is a big part of the diagnosis as well. And then we also have other webinars that go on, such as healthy eating, exercise, plant-based diets, and lots of useful tips that are all going to tie in tonight in terms of health style and building healthy habits to help with CHF management.
So the bad news is, if you have congestive heart failure, 50% of individuals will pass away within 5 years. That's the bad news. The good news is we have very effective therapy, and you need to learn about these things, and you need to put them into your daily repertoire. So we start off in saying is that step 1 is that you need to know your vital signs: blood pressure, heart rate, and your weight. Those are so crucial, and you need to do that on a regular basis. I encourage anybody who thinks they might have congestive heart failure to look at those videos. And then, if you want to become a doctor and learn more about how doctors think, which is important because you want to interact, is that look at the one on how to use the echocardiogram as well. So these are valuable tools. So next time when you come talk to me, you come from a position of knowledge, and knowledge is power. So I encourage you to learn more. They're fantastic videos that Monica and her team put together, so please explore this. And we're going to go through a lot of summations, a lot of this information, but they'll be there for your re-exploration. So please take a look at this. So if you're short of breaths, or you think you might have congestive heart failure, you've damaged your heart, let's find out how we can actually do some good repair work on it. So what is congestive heart failure?
What is it? That is a good question. So this is the most, I guess the best way to kind of explain it, just on the bare bones, is it's essentially the inability of the heart to provide adequate blood supply to the body, or it delivers blood at a higher pressure. Dr. Kernew has this great analogy of, if your heart is a car and it has these different parts, and one part is not working, or you have a flat tire, it's going to affect the overall performance of your car. And similar to the heart, we have a few parts that are working together, and we'll kind of get into them. And we have a part that's not functioning as well as it should be, so we're not able to provide all that blood supply to the body. Blood supply gives you oxygen, it gives you nutrients, it delivers to your organs, your tissues, your muscles. So if we're not getting that blood supply out to the body, then that's when we're going to have these symptoms of fatigue, shortness of breath, swelling. So we can break that down a bit more now.
So it's actually kind of you think about this. If the heart can't give you enough blood supply, you're going to be tired, you're going to be fatigued. If the heart's working at a higher pressure, the pressure is going to back up in the lungs. And if it backs up in the lungs, you're going to get short of breath. And when you try lying flat in bed, you're going to be short of breath because it's going to be more fluid in the lungs. then it's going to back up in your legs and your abdomen. Your legs are going to swell, your abdomen may swell. So this is actually very important, and that I will take a picture of this and pause this for everybody who's thinking about would they have congestive heart failure. So that's Brunwell's definition, and he's one of the experts, a great leader in cardiology, and this is his definition. I think it's the best definition I carry. So the heart can't give the proper blood supply to the body, or it does so at a higher pressure. Next slide, please.
So these are good. These are signs of heart failure, and it's a very good checklist to have a look at. So here it goes through the different types of symptoms that can arise. So there's shortness of breath that we've been kind of talking about since the start of this webinar, where we've called it breathing better. Shortness of breath when lying down, fatigue and weakness, swelling in the ankles, legs, abdomen, or base of the spine. Doctor, what are good ways to check for the swelling in the extremities?
Yeah. So first of all, you can see a lot of these symptoms are very non-specific. I'm tired, I'm short of breath, I have a big prostate, I can't pee as a guy, I can't do what I used to be. Is that deconditioning? Is that lung disease? Is it anemia? Is my kidneys not working? But clues of congestive heart failure, you rapidly gain weight. Let's say you gain 5 pounds over the last couple of days. One important consideration is that when you lie flat in bed, you can't stay there because you get short of breath. What's happening is the pressure inside the heart can't pump properly, or the pressure is high, so it accumulates in the lungs. You get short of breath. You have to sit up. You have to get up and walk around. If you try lying flat in bed, you have to prop yourself up on a couple of pillows. So if I hear somebody that says they go to bed at nighttime, they lie flat in bed, and half an hour later they have to get up because they're either gasping for air, they're short of breath, or they have to sleep on 2 or 3 pillows, that's probably congestive heart failure. So that's a big telltale. Being short of breath, ankle swelling, it could be all sorts of things. It can just be could be a weight problem. It could be deconditioning. So the thing is to look at your legs and see, do socks put indentations on your feet where that didn't happen before? I'm having trouble putting on my shoes. That's usually a sign of, or it could be a sign of congestive heart failure. So these are some of the things to think about. So this is sort of how you look at that. And because you get up at night and you have to urinate. Most of the time for us guys, it's a prostate problem, but also could be congestive heart failure as well. So next slide, please. So just think about, do you have any of these symptoms? Now this is actually a very important slide. This talks about the natural history of congestive heart failure. You can see these ups and downs. So what happens initially is that you get symptoms. You're short of breath, your legs are swollen, and the doctor treats you often with a water pill or some medications to treat your blood pressure. You feel better and you're stable. And then you go through to step 3 of stability, instability. And what we're seeing in heart failure, it's very unpredictable. Is that when is it going to be the next flare-up of heart failure? When is the heart not going to pump properly, or when is the stiffness of the heart not working properly? And you can see that the longer you have congestive heart failure, the worse off you are, especially if it's untreated properly. And the more exacerbation, so anybody who's been hospitalized for heart failure, that's a marker for poor outcome. And if you have 2 or 3 hospitalizations for heart failure, or ER visits, or flares up to your doctor, your mortality is much higher. So to me, one of the things is you have a very weak heart. Normal ejection fraction, as we'll talk about, is over 55. So if your ejection fraction is 20% or less, you unfortunately have a survival rate is in the order of 50% at a year or so. But we have good therapies we can add to that to extend quality of life. And if you've been hospitalized, especially multiple times for heart failure, you have a very poor survival rate. So these are the things that deserve extra care and extra attention. And the sad part about heart failure is, at first it's hard to recognize, but once you recognize it, we have effective therapy. But the clock is ticking. And it's always hard to predict the next flare-up of that. That's why weighing yourself on a regular basis becomes very important, and pick up the problems before it gets very bad. Monica, do you want add anything to this slide at all?
I think you said it best, Doctor.
Okay. There's one other thing I have to say as well, is that at some point in time, the congestive heart failure is very bad, and we have to think about comfort measures. And so it's really important that we'll talk about this a little bit later, is that congestive heart failure is not a curable disease. It's a very treatable disease. And you need to think about how you want to spend the remaining time you have left, what type of quality you have, and what you have to do. And basically, you need to have frank discussions. And I find that most of us don't talk properly about this, don't bring this up, and then we don't talk to our families about this. And usually a lot of the patients who have heart failure, who are suffering, often know when their time is coming, or feel that they don't want too much more. And pushing people to do things that they're not prepared to do, or offering things that do not add quality of life, is important. So there's a time and place for everything. In Canada, we are proceeding where you're allowed to, in many circumstances, decide when your life is going to be ending when you have poor outcome. But you can also see in heart failure, you can bounce back very quickly. And so it makes it a roller coaster ride. And so it can be difficult. So you need the help of people who know a lot about congestive heart failure. So don't be afraid to talk to people, especially experts in this area, to help you, because we have a therapy. And also be cognizant that this is not something that's curable, but very treatable. And there's a time and place for interventions, and there's a time and place for comfort measures. And you need to solve that and work with your healthcare team to get the best for you.
Dr. Kearney, what's the likelihood of getting a transplant or a ventricular assist device to go from a stage 4 all the way back to a stage 2?
Yeah. So it really depends on your circumstance. So basically, heart transplants are very rare. Assist devices are very rare. They're extraordinary measures. And they work best in someone who has a bad heart. Let's say you had a virus attack your heart. You're relatively young. Let's say you're 20 years of age. You had a virus that has sort of damaged your heart irreversibly. Getting an assist device or a heart transplant is game-changing. But going for a heart transplant when I'm 70 years of age, I have kidneys that don't work, lungs that don't work, I have anemia, I have bleeding problems, it's just not going to work. And so so heart transplantation assist devices are very infrequent. They're very specialized for the right person at the right time. It sounds great. And in practice for over 30 years, I've had 3 patients undergo heart transplantation. And it's added quality of life. One person died very quickly after their heart transplant because of rejection. But it's a rare event, and so it reminds me is that when my time comes, please take every organ in my body and use it for somebody else. So you have a card on your wallet, your driver's license that says, donate my body to science or whatever you want to do, or donate my organs. But that will not be acted upon because it's not a legal document in Canada. In Canada, if you can't make a choice, your family makes a choice for you. What you said on your driver's license is not legal documentation. In some countries, the fault of if you're dying in a car accident is to give your organs to others. In Canada, it's a voluntary gesture. And I would urge everybody to think about this, and we're going to do some more discussions about this, is that I wish the parts of my body can be used for others at the right time and right place. I still want to use them right now, but when my time comes, please use them for somebody else. And I think many of us feel that way, but we need to express that better to people around us. Next slide, please.
Okay, so now we're going to get a bit more into the structural part. Personally, I find this quite interesting. So congestive heart failure, as we've been talking, is essentially your heart is not pumping as efficiently as it should be. And that could be for different reasons. There are different types of heart failure. And we talked about how it's important for our body to receive all the oxygen and nutrients and have that blood flow. So as a result of the of heart failure, the fluid can start backing up in the lungs, into the liver, the abdomen, or the extremities. And here we have an image of the heart. So if we walk through the four main parts of the heart that you can kind of take away from tonight, we have two atriums and two ventricles. So the blood flow comes in from your body and it goes into your right atrium and then flows into your right ventricle. And then it'll go out to the lungs to get oxygenated. After that, it comes back into the left side of the heart through the left atrium, left ventricle, and then the left ventricle is responsible to pump it out to the body through the aorta. So if you think about it, our body is quite large. We have all the way from our head down to our toes. So our left ventricle has a lot counting on it. It's got to pump blood to the entire body. So it's got to be quite strong. It is the largest muscle in the heart, and it also fills with blood and pumps it out. So the left ventricle is where a lot of the congestive heart failure symptoms can stem from. But we could also have right-sided heart failure as well. So we can look into that on the upcoming slides as well. So before we get into that, once our heart starts to experience some type of failure, it's going to want to compensate. So it's going to do some different actions to help get the blood flowing to the body. So there's three things that it can do that we can break it down into. So as we know, our end goal is to get that cardiac output, so get the blood flowing. So the first thing the heart will do when it starts to fail is potentially enlarge. So the muscle will stretch out and become larger because it thinks, okay, if I can just make my heart a bit bigger, then I can get more blood flowing and maybe push out more blood. But in turn, what actually happens is it causes weakening and thinning of the heart muscle. The second thing is that the heart will increase the muscle mass. So it'll start to get bigger, like more muscular. And we would think, okay, more muscle, it can become stronger, pump out more blood. But what is actually going to happen is that it's going to have a decreased elasticity and decrease in volume of blood. So even though it's stronger, because the muscle has grown, it doesn't actually have the capability to hold as much blood as it did before to pump it out to the body. And then the third thing the heart can do is to pump faster. So this is where your heart rate comes into play, and measuring your heart rate and blood pressure is really important. So when your heart is pumping faster, it thinks that it's going to get more blood around to the body. But in fact, when you overwork any type of muscle, you're going to cause it to be strained. So doing that type of mechanism will also strain the heart. So these compensations can eventually fade out over time and not be efficient or effective. And then our symptoms will begin to worsen because our heart just cannot handle doing this for a long period of time, because that's not how it's meant to function. Its structure is not meant to be that way. So there are a few causes of heart failure. I'm going to just back up for 1 second because we have a quick animation of how this works. So the American Heart Association has this nice animation here where they show us a normal heart versus a heart that is in failure. So in a normal heart, you can see the blood is pumping at a good rate. The pulse is good. The ventricle is a normal size and it's flowing. And then if we take a look at heart failure, the heart is failing, so it's enlarged this ventricle here. You can see it's much larger than before. The wall is thinned out. There's a bit of a delay here with the pump, and it's just not as efficient as it used to be. So I thought that was a pretty neat animation there. I'll just hop back over here. So what causes heart failure? How can we get this? There's a few different causes. It could be a result of genetics. Over here on our slide, we have coronary artery disease. So that's when you have the buildup of fatty deposits in your arteries, and this reduces blood flow, and then it can actually potentially lead to a heart attack. Hypertension, so high blood pressure, it causes extra exertion, which will make your heart muscle more stiff or weak, and it won't be able to effectively pump blood. Valvular heart disease is damaged valves due to a heart defect or coronary artery disease or a heart infection, and this forces your heart to work harder. And when your heart is working harder, over time it's going to begin to weaken. And then also lifestyle choices can actually lead to heart failure in the end, as we're going to see in a bit. As you make specific choices, those can add up and cause a bigger effect in the long run. And as Dr. Kearney mentioned before, up to 40 to 50% of patients will die within 5 years of diagnosis. But medicine and our treatments are improving, so if we take the right steps, we can learn to manage heart failure a bit better now. So just moving forward with the structural stuff, there's a few types of heart failure. There's left-sided heart failure. So as I mentioned, your left ventricle is quite important in the heart. And if there's left-sided heart failure, you're going to get fluid backing up in your lungs because the left side of the heart gets blood from the lungs. So if that side is failing, that's when you're having that shortness of breath because there's fluid backup in the lungs. Right-sided heart failure, so the right side of your heart gets blood from your body. So if the right side is failing, then you're going to have fluid backup in your extremities, so your arms, legs, abdomen. And then left-sided can be broken down into two types. There is systolic and diastolic. So systolic heart failure is when the left ventricle is not contracting vigorously enough. Diastolic heart failure is the left ventricle is too stiff. So it's not able to relax to accept all the blood that it needs to in order to pump out to the body. So we can actually see using scans and different diagnostic tools what type of heart failure it is. And we've kind of already gone over the blood flow within the heart. And here's just an image of, so systolic heart failure is when the left ventricle has expanded and stretched thin. And then diastolic heart failure, you can see the muscle here has built up and it's a bit stiff. So it's not going to fill as much with blood versus a normal heart.
This is actually quite an important slide. If you just back up, you see the middle slide is that the heart is the left ventricle is bullet shaped. It's like the heart's not too thick, it's not too thin. It's sort of like, the porridge is too hot or too cold. So you want the heart to just be at the right size. If it gets stretched and enlarged, as you can see on the left, the heart loses its normal geometry. So when the heart contracts, it should contract like a bullet. It's like a ringing motion of the heart, and it just shortens, contracts in multiple planes. And so when it starts to lose the geometry of the heart, you get in trouble, and the heart thins out. So that's called systolic congestive heart failure. We've known about that for a long time. Diastolic heart failure is when the heart's working at a higher pressure. So you can see that the cavity is actually smaller, the heart thickens. So what happens is things like weight, blood pressure, diabetes, valvular heart disease stiffens the heart, it loses its elasticity, and so the heart has to contract, but the heart is, because it's thick and it gets scar tissue in it, it does it at a higher pressure, and that's called diastolic heart failure. And so I find this picture really helpful to visualize what's happening to the heart. And most of them may have a component of both. So you've had 1 or 2 heart attacks, so the heart muscle is being weakened and thin. But then you have high blood pressure, you're overweight, you're not exercising, your kidneys don't work, you can't get rid of salt and fluids in your body, so the heart becomes stiffer over time, so a combination of the above. So you can have a combination of both forms in that. So Just put that's a good image there. Next slide, please. Thank you for showing that, Monica.
Thank you. Yeah, and as well with congestive heart failure, the term ejection fraction is also used, and it's a good measure of how much blood the left ventricle pumps out with each contraction. So this is actually the equation here. So the amount of blood pumped out over the amount of blood left in the chamber. So we want a higher percentage of blood being pumped out versus staying in the chamber. And we can see kind of the breakdown here of what a good ejection fraction is versus a more dangerous measured ejection fraction. So if you're between 50 to 70%, that's considered a good range. 41 to 49% is this could be a bit dangerous, and then below 40% is when it becomes quite concerning. And this can be measured on the echocardiogram. So there's two types of ejection fraction. There's preserved ejection fraction, which is also talking about the diastolic heart failure, when the muscle has been stretched thin, and then that was preserved. For reduced ejection fraction, that's systolic heart failure, and that's when the muscle is not contracting effectively.
So simple to remember is that a normal amount of, every time the heart contracts, it ejects over 55% of its volume. That's what it's designed to do. So there's blood left over in the heart afterwards, and you can see that somewhere between 50 to 70% of the slide here. So that's a normal amount of blood volume. So if it's 60% or 55%, that's considered normal for most of us. The weaker the heart muscle, the worse off you are. And we mentioned at the beginning that if the amount of blood that's ejected is 20% or less, ejection fraction 20% or less, the 1-year mortality is about 50%. And we also have, it's important to actually, if you have heart failure, suspected heart failure, that we know your ejection fraction. Because if your ejection fraction is 40% or less, we have at least 6 drugs, medications to actually make you live longer and to improve your heart function. And it's remarkable. So it's not one medication, it's a combination above. We have something called mid-range ejection fraction. So, so if the heart muscle is between 41 and 50% or so, is that we're thinking a little different lines. And if your ejection fraction is over 50 to 55%, we have different therapies for that. So knowing your ejection fraction is actually one important consideration. And the echocardiogram is sort of the workhorse text for that. You can't guess the ejection fraction. You have to measure it, and the echocardiogram does that. There's other ways as well, but the most common one is the echocardiogram. And if you actually look at our video on echo and heart disease, you'll find that quite helpful, and there are more details to that. Thank you. So take that picture of it. It's another picture to say. What's this? Go ahead.
All right, so now we're just going to talk a little bit about the stages of congestive heart failure. So typically there's 4 different stages, and there's also another classification system that is more about the structure of the heart, and those are A, B, and C, and D. But we'll get into that later on. So I'm just going to go over these are more in terms of the symptoms that you might experience. So stage 1, you'll see breathlessness or tiredness. So this won't be too exhaustive, but as you progress to stage 2, you'll find those symptoms that we've been talking about, where you're comfortable when you're resting, your heart races, and you're feeling more breathless. And then stage 3, palpitations and tiredness are getting more and more pronounced. And then stage 4 is obviously where you're now becoming tired even when you're sitting, and you're more or less having shortness of breath all the time. So this is a good way of seeing kind of the progression, but making sure that you're always being aware of when you are experiencing shortness of breath. So I guess onto the next slide. There's different types of heart failure zones, and how do you kind of look at them and kind of check to make sure you're progressing or staying healthy. So these are things that you should do every day, and they're recommended by the Heart and Stroke Foundation, as well as the BC Heart Failure Network. And they consider things like, for example, your weight. to make sure that you're not gaining excessive weight over the course of a very short time period, because that's indicative of heart failure as well. Making sure that you're drinking a lot of water, you're taking your medicines like you're supposed to, and you're regularly checking for swelling, as well as all those symptoms that we've been talking about earlier. So this is a good reminder if you want to, pause the video or take a picture of this later so that you can make sure you're doing this on a daily basis. Now we're going to get into the kind of safe zones, and I know this might be similar to like a stoplight, as you might have seen. So the green, as we know, is good. It means you're in a place where you're not experiencing any of these symptoms, no chest discomfort, and you're making sure that you're taking care of your health. So this is where we want to be. When we have the yellow, this is a warning zone. And so this is the place where you should start to really make some changes and kind of alert your healthcare provider so you can take the steps to improving your health. So this includes things like, you're gaining weight very quickly, you're vomiting, you're feeling more short of breath, and basically you have all those symptoms that are worsening. And lastly is red, and this is undoubtedly when you should call and go to the emergency room right away, because this could mean you're having a serious event. And this is where you're very much struggling to breathe, it's very hard, you're feeling like you might pass out, that kind of stuff. And these are things that 100% you should go and go to the emergency room and get yourself checked out, because you don't want to take that risk. So now this last slide is just a summary of all of these stages that we've been talking about. And, oh, sorry, Dr. Canoe, do you want to say something?
Just so go back right to the first, oh, that's good. Go back to the first slide there, the category, the green slide over here. So basically, you want to prevent a trouble. So this is your car pressure. Your tires are properly inflated. So basically, you're feeling pretty good. Your blood pressure is 120/80. Your resting heartbeat's about 70 beats per minute. I weigh 167 pounds. I maintain that weight. Don't guess your weight. Measure your weight. Next slide, please. This is when you start, things are getting out of control. I gained a couple pounds over the last couple of weeks, or the last couple of days, excuse me. It means that you're probably starting to accumulate salt and water. I'm starting to have this dry cough. You can cough for all sorts of reasons. One reason is that the pressure inside the heart's getting elevated. The pressure in your lungs are, and that's called congestive heart failure. This dry, hacking cough. When I try to lie down, I'm short of breath. I feel uncomfortable. I have to sit up. Next slide, please. Now I'm gasping. I can't breathe. I'm just sitting gasping at rest. I try to take a deep breath. That's not the time to be at home. That's the time to keep specialized care. And it can happen very, very quickly. And it can happen slowly. So that's why monitoring yourself is very important. So when I hear people say, well, I don't know what my weight is, I don't know what my vital signs are, I don't know what pills I'm taking, well, if you have heart failure, you can either make yourself better or worse. And these are things to think about. Great. Thank you for sharing that. Next slide, please. Go ahead.
Yep. This is just a quick summary of all the zones we were talking about, but I think Dr. Kearney really covered it very well. So again, you want to shoot for the green, and if it's red, don't take the risk and just go and get yourself checked out. And then so here on this last slide, we're going to be talking about these are the Canadian Cardiovascular Society guidelines, and so it kind of shows you how we kind of decide, almost like a detective, kind of figuring out different tests that we're going to conduct so that way we can confer a diagnosis and really get you the treatment that you need. I don't know, Dr. Kearney, did you want to mention anything about this slide?
So what you see here, the normal, the green parts, but then you said, I'm short of breath. So let's try to figure this out a little bit more. You mentioned that word BNP or pro-BNP. So BNP is called brain natriuretic polypeptide. It was discovered in the brain, but we actually found out it contains in high concentrations in the heart. And we're going to talk a lot more about this. And there's two forms that we commonly measure, BNP or NT-proBNP. They're somewhat different, but they're derivatives of the same equation. And so I have my fudge factor somewhere between 2 to 4 times, 3 to 4 times. So BNP times 3 to 4 equals proBNP. And we have different cutoffs. So there's not one absolute number here. And I like this idea is that it can quickly go up if you get very sick, or can gradually go up. So numbers to start to think about: if I have a BNP over 50 or NT-proBNP over 125, I have to think that the pressure inside my heart's elevated and that I could have congestive heart failure. So, I'm overweight, I'm deconditioned, I'm anemic, I have underlying lung disease, I have a smoking history. What's going on? In many circumstances, BNP or pro-BNP can be a marker. In fact, if you have a pro-BNP greater than 1,000, or you have a BNP greater than 300, that unfortunately can be a marker for death. And so you need to have, so you don't want to ignore those numbers, and those needs to be investigated. So I really like these numbers. The problem is these tests cost $75 to do at the labs. They're not covered by the government at this point in time, but they're very valuable. And you can decide with your doctors, and especially with someone like myself, is that I've gotten to learn and how to use these numbers, and they've been so valuable. It helps say this, how much of your heart failure is related, or so much of your shortness is related to heart failure, or some other causes of this. The echo part is also an expensive test, but it's covered by the government, and it gives me so much information, and I encourage people to go back and look at these videos. But BNP or pro-BNP can be very important markers, and they're very valuable. Anything else that you want to add to that at all?
No, I think we're just going to head on over and kind of go over, as Dr. Kearney mentioned, all the different ways we actually can diagnose heart failure. And so this is kind of just going to be a comprehensive review of different ways that we might be testing, so that way you know exactly what we're getting from all the tests that we're doing. So the first thing that, if you haven't noticed by the rest of our presentation, is very important, is symptoms. And what do we mean by this is we mean that it's really important to report them, to be cognizant of them, and to make sure that we're being aware of them so we can manage our health properly. So we have a little, a game, if you could say here, where we have 3 different symptoms, and we're going to try to put them into categories if we think that they're more in terms of symptoms that you may notice first. Something that you may notice is your condition worsening, or something that's associated with a very severe heart condition. So I'll give you a little bit of time now to just look over it, and then you can obviously pause and test yourself after.
So blue skin, I painted myself blue as one possibility, I guess. I'm always tired. I'm always fatigued. Irregular heartbeat. That's interesting. What does all this mean? Tell us, Matthew, what's happening?
Of course, Dr. Kearney. So if we go to the next slide, you can see here that these are symptoms of congestive heart failure. And so fatigue, as we mentioned, or shortness of breath as well, can be very common in terms of these early symptoms. And that's why you should report them, so we can get to the diagnosis as early as possible and really help you before it's too late. And then the middle, we see an irregular heartbeat. So these can be either arrhythmias, they can be these can be very noticeable in your ECG, which is a testing method we'll get to later on, which is the electrical signaling in your heart, as well as the way it beats, because this can be very indicative of how your heart is actually functioning properly. And lastly, if you do see your skin appearing blue, that is a very severe issue, and that's called cyanosis, and that's when your body's actually your tissues aren't getting enough oxygen, and that leads to them turning this bluish color, and that means that you should really go and see your doctor and make sure that obviously if you begin to faint or feel faint, as we mentioned before, that you go see the emergency room right away.
So it's really important that you understand your body, and there's not one symptom that says for sure I have congestive heart failure. It's a combination of all the above, and you need to learn your body, understand your body. So thank you for sharing that, Matthew.
Okay, so it's that time of the presentation where the word we've been saying is finally going to be discussed. So BNP, it stands for brain natriuretic peptide. And as we briefly mentioned, it can be a biomarker for congestive heart failure, and it's usually measured with a blood test. So as Dr. Kearney already said, it costs $75 to get the blood test to measure this. It's not covered under the other options that you could have during a blood test. And the thing with this marker is that it could be quite helpful in helping to diagnose. But there are some things we have to think about because it can change with your age, with your weight. If you're not feeling, if you're sick, it can go up. But essentially, when your heart is working harder than it should be, then your body releases this BNP, and then so that's why we can use it as a biomarker. So there's a few other things in terms of the value that we look at. So here it also says 125 for NT-proBNP and 50 for BNP, but the values can change, as I said, depending on if it's acute or chronic. And yeah, so over here as well is the clinical evaluation and the risks and benefit of the actions, which should be considered. So for heart failure, these are the values that they quickly look at. For ambulatory heart failure, so when you need to go to the hospital, it's usually 30% higher from the baseline value that's listed here. And then if you're hospitalized for heart failure, it could actually be greater than 30% decrease from the admission value, and then discharge if they are relatively free of congestion.
So this is interesting. So if your BNP is less than 50 or your NT-proB is less than 125, you probably don't have congestive heart failure. I'll repeat that. If your BNP is less than 50 or your NT-proBNP is less than 125 and you're not really massively overweight, because being overweight actually depresses the value, you probably don't have congestive heart failure. So that's interesting. I mentioned that if your proBNP is over 1,000, that catches my attention, and I really worry about you, because if you're not properly treated, you may die soon. Sometimes it can be chronically elevated, and sometimes it can rise acutely. And one thing that can be used is that if you're being treated for congestive heart failure, it should fall by about 30%, and that's usually a good sign. And so these changes are important because there's also variation, and if it hasn't changed by 30%, it's still within the same measurement error there. So I think change in 30% is actually important, and the actual value and what your BNP or proBNP should be. For instance, I take care of a lot of people whose proBNP is at 4,000 on a regular basis. So they're under observation. Some of them look really well, but I know the pressure inside the heart's elevated, so I have to treat them differently. So I really think it's a wonderful test. It's not a test you need to get every day, but it's a test when you're confused. And we'll show some more examples of that right now. So this is the newest test out there. Most family doctors don't know how to use this yet, and my hope is that they'll learn to use that more. I'm still learning how to use this test better, because I participate in a number of projects, have the ability to do this for a number of years. I've learned to use this, and I really find this to be helpful. We have to decide with you if that's the right test or not, at the right place and the right time. Thank you, Monica.
Yes, I was actually initially drawn to join Dr. Kearney's clinic because he was actually utilizing this new test, and he's always progressing and looking for new innovations in medicine to help his patients. So I think it was pretty neat. It definitely caught my attention. So there are also other values for BNP. So depending on research and how it's going, the values kind of vary. So on the previous slide, it said 50. Here it says if you're less than 100, then you're considered normal. And there are other factors to consider, and kidney failure is actually also affects the value. So if you have kidney failure, the cutoff increases for BNP to be considered a normal value. And
so the kidneys, if you just backtrack, the kidneys actually cause us to go up, and also depends if you get acutely short of breaths or if you're chronically short of breaths. So the value we showed you before is more for chronic, and this is more acute. Like I suddenly get short of breath. It's a brand new circumstance. The value less than 100 is probably means the shortness of breath is not related, but if you're chronically short of breath, around value about 50. As you get older, as you get kidney dysfunction, we have to adjust those values as well. So here's what kidney failure or your kidneys start to fail. And I won't say total failure, but just in the and we're going to eventually do a webinar on what's in the blood, and we'll talk about how to look at that. Next slide, please. Tell us about this, Monica.
Yeah, so based on Cleveland Clinic, they suggested that if you have greater than 300 picograms per milliliter, and you're between the ages of 50 to 75, that's considered elevated, and that's when further testing would likely be done. As Dr. Kearney mentioned, he treats patients with over 4,000, and it's just under observation and even over 1,000. So Dr. Kearney, what do you think about greater than 300, is it?
Yeah, so I think you have to learn to interpret. So I don't want you to walk around there's one value. And it's nice to know what people's value are and how they change over time. And we know as you get older, it will go higher. As your kidneys weaken, they'll go higher. And interestingly, is the more overweight that you get, and that's a surprise, is that BNP seems to accumulate maybe in fat tissue, it gets lower. So we need to make some adjustments. So this is just one component. So I don't want people to walk out and say there's just one value, but it's really an important tool in the repertoire of things. And I'll show you some examples where it really is helpful as well. Next slide, please.
There's a similar blood test. So NT-proBNP is just a precursor of BNP. So it can also be found in the blood, and it can be measured. But the values do differ a bit. And as Dr. Kearney said, it could be a factor of between 2 to 4 times what the BNP value would be. Dr. Kearney, do you think that everyone should get a BNP test at least once? Or
yeah, it's nice to have, but I don't think it's sort of a luxury. For many people, I don't need it. For instance, is that if you take a drug called Entresto, which is a valuable drug in the management of heart failure with a bad heart, it actually causes BNP to go up. But in that case, you need to use NT-proBNP. And if you're going to go for surgery, and if your proBNP is above 400 or so, your risk of complications are higher. So if you're an older person thinking surgery, you can actually use this to help predict risk. And so it's just one of those tests that can be helpful. Next slide, please.
And these are the elevated NT-proBNP levels. So similar to BNP, the values can differ depending on the research study, but these are kind of a mark of where once they reach greater than 450 or over 900 for patients that are 50 years or older, where it could be a bit concerning and proceed with more diagnostic measures.
So these values are for more acute decompensation. I suddenly got short of breath, I'm in the emergency room. But for chronic heart failure, results are different. And of course, you're going to show us what happens in atrial fibrillation and irregular heartbeat. Next slide, please. So it really is, it's a valuable marker. And so if you have atrial fibrillation, it goes higher. But there's other tests too as well we can use. Tell us about the chest X-ray.
All right, awesome. Yeah, so we're going to go on to the chest X-ray. And so this is relatively a short, painless procedure that kind of is used mainly to image your heart and lungs. And so what does this tell us? It tells us that whether the heart's enlarged, as we mentioned before, with that hypertrophy, or if there are congestion or swelling of the lungs. So these are two really important indicators and could be used to help diagnose chronic heart failure and also be used to identify potential reasons for our shortness of breath. So this is a good way to do it. Yeah.
So you could have pneumonia that we can miss, you see. So and you could have something called the pneumothorax, a puncture of the lungs. You can have a cancer in there. You can actually have other things going on in there. So the chest X-ray is one tool to look for signs of congestive heart failure and other causes of why you might be short of breaths as well. So that's something your doctor may organize. In fact, if you go to the emergency room with shortness of breath and you're quite sick, there's a very good chance you will have a chest X-ray done. The problem is if you go to your doctor's office to do the chest X-ray, you have to go to the doctor's office to send you a sheet. You have to go get it somewhere else, and the report comes back, and it's a long delay. So if you're really sick, as you mentioned, go to the emergency room. It's still the best place to be. If you're not so sick, one has time to evaluate. Each case is different.
Exactly. Yeah. And then the next one, I think, again, we've talked about it many times, but it's the echo. And so the way I kind of, if you're familiar with, I guess, an ultrasound, for example, with pregnancy, you're familiar with the technology that's used. It's a very similar method where we take kind of the way that, like, when you hear an echo, you shout it out, and then you can hear the sound come back. And that's similar to how an echocardiogram works, if we go to the next slide, where it uses these these ultrasonic sounds, which it kind of, I guess, releases into your chest, and then and the sound will come and bounce back and will be red, and that's how you get this like beautiful image here that can show you the way that the heart's pumping, how it's moving, and all of that. So as we mentioned before, this is one of the best ways to check your ejection fraction that can be measured, and this can help define whether you have heart failure with a preserved ejection fraction or a reduced ejection fraction, as well as telling you other things like the thickness of the heart muscle. And this is, again, a typically non-invasive procedure, and the only discomfort you might feel is the gel that is used to put on your abdomen might be a little bit cold. But other than that, it's relatively quick and tells you a lot.
So you get to know what the heart valves look like. You look at what the surrounding tissues. You look at the sac of the heart muscle. So much valuable information. So I'm lucky to have a machine that adds to your care. Next slide, please.
Exactly. And yeah, so in terms of why, again, it's really important is because there are many different reasons for dyspnea, or shortness of breath, and this may mimic heart failure. So you might be experiencing shortness of breath, but that might be due to a completely different cause. So, and these are just some of the many causes of shortness of breath that are possible. And so that's why when we go to the next slide, we have the H2FP scores.
Let's go back one slide back here. So that's why is that you're short of breaths for all sorts of reasons, and these are some of the things that are important. You have a valve that needs to be fixed. You need to look at that. If you have a pneumonia, you need to have that fixed. If you're your kidneys don't work, you can't get rid of the salt in water, that'd be another issue. If you're just depressed and sad, you have a blood clot. So many causes, and that's why where BNP and pro-BNP can be helpful. I'll never forget one of the first times where we had this patient that was coming back to hospital on a regular basis. He was short of breaths, and his chest X-ray looked like it was congestive heart failure. He got treated for congestive heart failure. He got a little bit better, but not that better. And then this new test called BNP came up, and we did it. And it was very low. I said, wait a second, how can this person with congestive heart failure have the low pressure inside the heart? What's going on? It turns out we had the wrong diagnosis. 10 doctors made the wrong diagnosis. What he had is scar tissue called pulmonary fibrosis. So scar tissue in the lung that looked like congestive heart failure in his chest X-ray. His lungs sounded like congestive heart failure. He just wasn't getting better, but it was all scar tissue. And the chest X-ray couldn't tell the difference between scar tissue and fluid. They looked the same. And it wasn't until that we did this test and we paused and got the right diagnosis. And it turned out to be a medication called amiodarone, which rarely can cause pulmonary fibrosis. So that can change the diagnosis at that time. So I'm always humbled that you have to always look. And many people have more than one cause of their shorter breaths. You can say, I'm just getting old, I'm just deconditioning, I'm just overweight, I just have too much high blood pressure. We can do better, and most of the time people have a combination of all the above. So thank you for sharing that slide.
Mm-hmm. Yeah, I think we always like to think, medicine is, hopefully we just go in, we have a for sure diagnosis, and then we go away with our treatment and everything's good. But sometimes it's a little bit messier than that. There can be a combination of factors. There can be a very unclear cause. So that's why it's always important that we're monitoring our symptoms, really checking in with our doctors, so that way we can make the best clinical judgment. And then this tool really helps out with that as well, where it's kind of a score that kind of predicts the probability that what we're seeing is actually heart failure and not something else, as Dr. Kuhn, you mentioned. So it looks at different things like, your weight. Are you hypertensive? Do you have atrial fibrillation, which is an abnormal heart rhythm? Do you have pulmonary hypertension? Are you elderly? And how's your filling pressure like? And a lot of these things can be figured out based on the tests we talked about, namely an echocardiograph. So as you can see, like pulmonary hypertension and filling pressure can both be measured by echoes. And this puts you on a scale, and based on if you have multiple of these factors, it's more likely that you're going to have something that's heart failure and not something else.
So this is something I would everybody take a picture of. So if you have atrial fibrillation, I did a presentation with a lung doctor once, and we talked about how much is the lungs, how much is the heart. And so he described a 65-year-old patient that had atrial fibrillation, that was overweight, that had high blood pressure, and he was trying to tell me that this problem was his lungs. Well, you know what? If you just have atrial fibrillation, you get 3 points. That gives you a probability of heart failure for shorter breaths by 50%. Now, once you make it to the age of 60, because usually heart failure is a disease, as we get older, the heart wears out, loses elasticity, you get a point for that. If you have a body mass index over the age of 30, you get 2 points. So if you're 60 and you're overweight, body mass, you get 3 points. The probability your shortness of breath is from heart failure is close to 50%. Now you have high blood pressure and you're taking 2 drugs. The points keep adding up. And so basically you can see that being overweight, being on blood pressure medications, 2 medications, and being over the age of 60, that's 4 points. That gives you a probability of heart failure by 70%. And so to me is that work on your weight. I don't know how to stop the aging process. I think I actually do, is that by basically exercising and being vibrant and just kidding, but I think, don't act your age. Just be active in your life. So, and the pulmonary hypertension and the filling pressure, those are echo parameters. So to me, this is really important, is that what we're learning is being the ideal body mass index is 20 to 25. And very few of the patients I look after are at an ideal body weight. Now, it only took me about 61 years to get to my ideal body weight. Will I maintain it? I don't know. But I have the help of so many people around me. And most of these young people that help in these presentations and run our workshops are contribute to clinics right now. So please take the opportunity to take this seriously. Is that you want to treat your blood pressure, you want to treat it properly, you want to measure your weight. We talked about getting a blood pressure machine and getting a scale. People talk about every Canadian who wants one should have a vaccine. Every Canadian should know their blood pressure, their body mass index, should have their own scale, and have their own blood pressure machine, period. And you can share it with your family if you'd like to, but that's kind of important. So I think it's a very important slide. So just pause and take a look at that. Next slide, please. This is how you make a diagnosis of diastolic heart failure without even examining the patient. This is more complicated. This is actually a great slide that talks about, on the left you have the criteria we talked about. On the right, we have some more sophisticated parameters including the echo parameters, the BNP values. You can see it, the biomarkers. You can see as your BNP is over 50, your pro-BNP, I can't read that number, it's probably somewhere over 200 range. And you can see that if you're in atrial fibrillation, you need to adjust for age and things of that nature as well. So it becomes even more sophisticated. So you can tell a lot on your far left by just knowing your age, how much you weigh, and what your blood pressure is, and whether or not you have atrial fibrillation or not. Or we can add other parameters to add that equation. So the first thing to remember is that congestive heart failure is a symptom complex, and we can actually look for changes in the heart. We talked about thickening of the heart muscle from high blood pressure, from being overweight, from valvular heart disease. The elasticity of the heart, we can actually measure that by some of these parameters here. So, and the BNP adds to that equation there. Matt, do you want anything more about this slide you want to add to this at all?
No, I think everything was covered. Yeah, so I guess we can just move on to the next slide. But yeah, as Dr. Cooney says, very important.
And this is a slide that you should think about learning about. Okay, next slide, please. So we talk about the tip of the iceberg here, and it's easy to recognize class 4 severe heart failure. You're gasping, you're blue, you look like you have no blood pressure, your heart rate's very high, your oxygen saturation is very low. That's the tip of the iceberg. But what's under the surface is really important too as well. And that's why we tend to, and people say, well, you know what, I feel good. I have high blood pressure, I've been overweight all my life, I have some diabetes, but I feel good. Good. I want to keep you that way, but look at that iceberg. You're not going to be good. You're going to develop congestive heart failure. So what are you waiting for? Till it's too, and people I can understand why everybody's developing heart failure. Go back one slide. So if you go back one slide, this is why you're developing heart failure, because you're having all these changes are taking place. Next slide, please. So you're just going to wait till you're ready to die? Is that what you're going to do and react to this? No, we got to be more proactive about this. So that's why I'm really working hard at my lifestyle changes. And that's why I'm looking at the right test at the right place and the right time. So next slide, please. So this should be a wake-up call to everybody. Who's talking next? Who's going next?
Oh yeah, just wanted to, I guess, wrap up on the testing that we're going to talk about, which will actually lead into what we're going to be talking about after. So this is just the last kind of main thing that we will commonly be done is the electrocardiogram. And this is, obviously they'll put some electrodes on your upper chest, and this will tell you different things. It'll produce a trace similar to the one, as you can see, moving on the screen. And it'll tell you, for example, if you had a heart attack, but most importantly, it'll tell you if you have an abnormal heart rhythm, which is what Dr. Cooney was talking about before in terms of atrial fibrillation. And so it'll show you a trace similar to the one on the right, where it'll be very noticeably different and not normal, suggesting that the pumping and the electrical signaling within your heart is actually problematic.
So an ECG is a relatively easy test to do. It's relatively inexpensive. I think in Ontario, it costs about $12 to do or something along those lines. It's a test we do almost on a regular basis with many people prior to the pandemic. Right now, unfortunately, we're doing very few electrocardiograms on people because it exposes people at risk right now. So I'm hopeful. I look to the day when we can go back to looking at ECGs more on a regular basis, but it's a good tool. Now, you can also do an ECG on yourself. There's something called the cardiac device, K-A-R-D-I, K-A-R-D-I-A, or the Apple Watch now can do different rhythms and things of that nature as well. So, you're going to be a doctor in yourself right now, so there's different devices that are now available electronically you can look at. ECG is a valuable tool. You can see it's not one test, it's a combination of all the above. Thank you for sharing that. Next slide, please.
Mm-hmm. And just an adaptation of this ECG is actually applying it to an exercise stress test. And this is really good for determining how your heart actually responds to these external stresses, like increased heart rate or exercise. So this can tell you the blood supply is being reduced in the arteries supplying the heart themselves, or what is an appropriate level of exercise for you. So this is, again, really nice if you want to become active and really make those lifestyle changes, but making sure you're not overdoing it, this is a great way of evaluating how strenuous your exercise can be.
Well, to me, the stress test is another wonderful tool. You get a resting ECG on it. You exercise the heart, and we can learn is how physically fit you are, what happens to your blood pressure, the rhythm problems. So, in fact, during the pandemic, we're actually doing more stress testing because you get a lot more information on a stress test than you do from an ECG. So, if we're going to expose ourselves, we want to get maximum benefit for you in a timely fashion. So stress testing, and I thank Lily for doing this, and I thank Rabina and Artie for doing the echoes and things of that nature as well. So they give you lots of information. Remember that the more fit you are, the longer you live, and the stress test can look for that. So everybody should know how many METs they can do exercise. So that's a different discussion. Thank you for sharing that. Next slide, please.
Okay, so this slide, I guess maybe try clicking again. Maybe there's a transition on this. There we go. Okay, so I think arguably this is a very important slide because it really does a good job of summing up, okay, you have a diagnosis, so what, and kind of what you can do about it. So the first thing is, as you can see, based on the stages, C and D up there are what I've been talking about. This is where you establish a diagnosis, as Dr. Cooney mentioned, that top of the iceberg, where you have marked symptoms, you have known structural heart disease, shortness of breath, and reduced exercise tolerance. So you have these very visible symptoms. And this is what we were talking about, where all of the statistics came from, where we were talking about how upon the diagnosis, you have about a 50% 5-year survival rate. And here in the study actually is where it was derived from and breaks it down, where you see that if you're in the end stage or stage 4, stage D, you're actually only going to have a 20% survival rate after 5 years. And if you have a C, you're going to have 75%. And so average out, you get that around 50% mark that we were talking about. And this is, really scary because the diagnosis itself is something where it's very late in the game, as we mentioned. So what can you do about this? Well, if you see stage B and stage A, and you look at the survival rates, stage B is actually 96% survival at 5 years, and stage A is 97% at 5 years. And this is actually pretty comparable to a healthy or non high risk for heart failure individual who's actually only at 99%. So if we look closer at these stages, we see that stage B and stage A these are things where you have, for example, hypertension, coronary artery disease, diabetes, you've had a previous heart attack, or you have an asymptomatic valvular disease. And so when you see these things, it should be kind of like a red flag, and you shouldn't let it progress any further because you are at risk for heart failure. Because once you get that diagnosis, then we're talking about a very marked decrease in survival. So that's why it's so important that you look for these and determine whether or not you are high risk. If you have any of these underlying causes, and address them, change your lifestyle when you can. That way we don't get to those later stages of HF, and so that way you can live a longer and healthier life.
So I love this slide a lot here. And so if you remember one of the first slides, we showed you that heart failure is a roller coaster ride, episodic, and can occur very suddenly. You can become a D or C within minutes, and you've been an A and B for years. In fact, most of us are on a progressive course to develop heart failure if we're not careful. Our hearts are wearing out. And so that's why you have to train your heart. And please don't wait. So, I'll get a blood pressure machine next time. I'll take my pills next time. I'm too busy to look after myself. You know what? You're not too busy. You have to make it as a priority of your life, because I have a lot of energy is because I train myself. I keep working at this. And so please take an initiative. Don't wait till it's too late, because once it's advanced, if you have to say you have a 50-50 chance of being around the next 1 to 5 years, that's terrible. And when you could have done something about your blood pressure, you could have done something that you had a valve problem that you didn't know about. You could have done something about your weight way back when. You could have done something better about your diabetes. So the time for action is today. Good maintenance. I don't know about you, is that most people go for an oil change. They check their tire pressures from time to time. Give your body the maintenance it deserves. Next slide, please. I think you've seen the slide before, is that, again, if you're hospitalized for heart failure, you're in trouble. And so if your body mass index is over 30, you're not managing your blood pressure, you don't know your blood pressure, you have markers of heart failure. So when I think of congestive heart failure, I think about your symptoms, I think the structure of your heart, and you can measure the neurohormonal activation. But you're in control of these sorts of things. And French fries are wonderful, but they kill you. People say moderation. We're not in moderation anymore. Moderation means you have a body mass index between 20 and 25, and you take liberties. If you're in trouble, you need to work at it. And I know it's hard, but you know what? You'll feel so much better. And the people around will love you that much more. So just think about it.
Mm-hmm. And I guess just to finish, sorry, Dr. Cooney, did you have something else to add?
Well, go ahead, Matthew. Go ahead.
All right, awesome. So we just wanted to finish it off with kind of looking at diabetes specifically. So type 2 diabetes increases heart failure risk by a lot. As you can see here, various studies show different things, but it's usually around up to 2 times in men and up to 5 to 6 times in women, which is an extreme increase in your risk. And interestingly enough, we might think that, it's because, maybe I just have a high blood sugar or I'm not managing my glycemia properly. But studies have actually shown that the prevalence of HF and the risk of developing it was still higher in diabetic patients who did have their blood pressure under control. So it's just having diabetes itself puts you at a greater risk of developing heart failure. So even if you are, and we obviously do, encourage you to really manage your blood pressure properly, because that's a very important thing to do, especially if you're dealing with diabetes. But we don't want you to say, okay, my blood sugar is okay, so now I can just forget about heart failure, because that's unfortunately not the case. And so we should always be looking for those symptoms, always be checking up with Dr. Curnew and making sure that we're making these decisions to better improve our odds of not developing heart failure, especially when we're at such a high risk with diabetes.
Yeah, thank you for sharing that, because diabetes is a great fertilizer for blindness, kidney failure, amputations, heart attacks, and strokes. We're going to actually send a webinar on how to put diabetes into remission. It's possible. And for most people, it's losing 20 to 30 pounds and keeping it off. Diabetes is no longer a disease of blood sugar. It's a very complicated disease. And that's why over the last number of years I became very interested. We have better therapies, better medications, better lifestyle changes. We're privileged to have 2 diabetic educators work in our clinics. Those are usually confined to family doctors. I'm becoming very knowledgeable about diabetes, not because I want to, it's because I have to help to give the care that you need. It crosses every subspecialty from dementia to kidney failure to blindness. So it's very important about this. So diabetes is something that is manifested by a blood sugar. I urge people who have diabetes. We just did a webinar that was just released yesterday that talks about how to manage your diabetes and the complications. We're going to be talking about shortly how to put diabetes into remission. So this is important. So please take your diabetes seriously and treat it properly. Give this disease the respect it deserves.
Awesome. Yeah, thank you. Thank you, Dr. Curnew. And I'm just going to pass it off to Monica again, and she's going to talk a little bit about how you can actually take these things that we've talked about and manage your risk for chronic heart failure.
Yeah, I feel like I'm still learning more and more every time we do these webinars, so it's great. We've talked a lot about the diagnosis and what CHF is, and now we're going to really dig deeper into how to manage it. As Dr. Kern, you said, it's not curable, but we can take steps to manage, and that's what we're going to get into now. So here are some key things to always keep in mind whenever you visit your doctor. You need to be telling your doctor if your blood pressure is greater than 90 to 100. Or
Yeah, should be less than. Should be less than. Yeah.
As I was reading that, I was like, less than 90 to 100. So that means you have too low of blood pressure. Even if your blood pressure is also too high, you should be telling your doctor.
So if your blood pressure at home is greater than 140 on a regular basis, 140 over 90, or if your blood pressure is too low, you and your doctor need to have a discussion about this. And it's the home blood pressure that's more important than the office blood pressure. Go ahead there, Monica.
Yeah. So having a blood pressure machine is important for that, and it's also important to measure your heart rate. So if your heart rate is consistently above 70 beats per minute, it's something to tell your doctor. Dr. Kernew, you say we should aim for around 60 beats per minute.
Yeah, if you have heart failure, ideal heart rate is around 60 beats per minute, and people have normal sinus rhythm. For atrial fibrillation, it could be faster.
Okay. Yeah, so if it's above 70 consistently, it's definitely something to bring up in that case. If your potassium is greater than 5, if your eGFR is less than 30, so these are based on blood test results. So if your family doctor is ordering blood test results and you like to keep up with your lab results, this is a good moment to mention we have a great webinar series for technology about how to access your lab results online. So you can do that. Make sure you check out those videos. Or if your hemoglobin is below 100, these are all things to just keep in the back of your mind, track, and just if you are breaching any of these thresholds, make sure you do speak with your doctor.
So you can see that the heart is just part of your organ system. So if your kidneys are not working, a normal GFR is usually over 90%. And if your potassium is above 5, it can cause a rhythm problem. Or if it's less than 3, it can cause a rhythm problem as well. If your blood counts, you're too anemic, hemoglobin less than 100, these are red flags. So you should be the one telling your doctor, Dr. Kernew, my potassium is 5.5, my GFR was 60, it's now down to 30, and my hemoglobin was 120, it's down to 80. What the next step should be. I love conversations about this. And if you put answers as well, you should know. The answer is we all should know together, and you should be part of the solution versus part of the problem. So just think about how you can be an active partner in your health. Love those discussions when people are active partners. If you're waiting for somebody else to look after yourself, people will do the best. But I think you need to be active in your health right now, especially right now how the world's changed right now. So things are done remotely and will continue to be remotely for many years, the rest of the time over time. Thank you for sharing that, Monica.
Thank you. Okay, so medications. So medications are really helpful, and they're designed to help treat several things. In the case of heart failure, we have 3 goals when it comes to medication. To decrease the likelihood of your disease progressing, to lessen your symptoms, and to improve your quality of life at the end of the day. So it's really important to listen to the doctor when he's prescribing medications. If you have questions, ask the questions, and always keep an updated list. So we're going to go through the most common medications for heart failure. We had a little quick activity if you wanted to pause the video and see if you can match the name of the medication to its function. But we're going to just get right into talking about it here. So these are just the most common ones. We have digoxin, and digoxin will help strengthen the force of the heart's contractions. So this is going to help with the blood supply being pushed out of the heart. There's spironolactone, which is a diuretic, but it's specifically for potassium-sparing diuretic. There's Lasix, which is also another form of diuretic, and it will increase the excretion of water and sodium in the urine. There's Entresto. Dr. Kearney has mentioned that one previously within this presentation, and that helps to relax blood vessels to help improve blood flow. There's ACE inhibitors, or ARB, and that lowers blood pressure. It acts as a vasodilator. And there's also beta blockers, which will slow the heart rate to allow the heart more time to fill with blood.
Now, it's kind of interesting is that we also know that these drugs block hormones such as BNP, affect pro-BNP and things of that nature as well. So, and what's going to be added to this list is something called SGLT2 receptor antagonists that work as well. They're discovered in diabetes, but they're phenomenally good drugs for congestive heart failure as well. So you can see that you have 6 categories of drugs that can be of benefit in the management of heart failure. Remarkable. Next slide, please. And this is why it is so important. Tell us about this slide here, Monica. Do you want to tell? I love this slide. This is actually important.
Would you like to take it away, doctor?
Okay. So if you have congestive heart failure and you're on no therapy, the mortality is about 35%. If you now go on medications, all these categories of medications, so if you go on a beta blocker, it decreases the chance of dying by 25%, 28%. Aldosterone blocker by 30%. ARNI or ACE and ARB therapy by about 15 to 30% reduction. You go on SGLT2 receptor antagonists by 70%. So you can transform a 2-year mortality from 35% to reduce it down to 9.5%. Remarkable. And it's not one drug, it's a combination of drugs. But how to use this combination, that's my job to help figure that out with you. Each medication has its pluses and minuses. So if I have congestive heart failure, you mentioned if my ejection fraction is less than 40%, you should be considered for all these agents, as many as you can in combination at the right dose in them right now. So this is remarkable. This is a game changer. You can see that beta blockers have been around for a long time, and they probably have one of the best reductions in mortality historically, getting your resting heart rate down to about 60 beats per minute. And if you can't get your resting heart rate down to 60 beats per minute normal sinus rhythm, there's another drug called Vabradine that you can add to that mixture as well. So we still have lots more in our toolbox right now. Next part of the slide here. And you can see that the newest kid on the block is something called SGLT2 receptor antagonist. I love these medications. We'll show a little bit more about them. They not only treat your diabetes, not only help you lose weight, but more importantly, they prevent and treat heart failure and changes mortality, independent of its blood sugar effect. So if your heart muscle is being weakened, it is part of the repertoire of medications. The other thing too, it's more gentle on the blood pressure. It's quite nice, and also it protects kidney disease and actually decreases the chance of end-stage renal disease by about 40%. So you can see that we have so many tools in our toolbox. We start off with the tip of the iceberg when you're sick, and that's these medications you need. But treating earlier and more aggressively with lifestyle changes is important. So when it comes to end-stage heart failure, we have very good therapy, but my hope for most of you is that we don't have to use these combinations on you. But if you have end-stage heart failure, we need to mix and match in combination therapy. Next slide, please. So wonderful. So again, and that's why we have to be attentive to your potassium, your kidney function, your blood pressure, because certain medications will affect them. So things like Entresto, ARB, ARNIs, spironolactone affect potassium and renal function, and some of your symptoms there. So really important that we use them wisely. Next slide, please. So I'm just so impressed that you need to keep your list up to date right now. And so you need to know when you're going to be running out of medication. So I encourage everybody to look at the videos on prescription renewals as one of your priorities. because if you're going to count on doctors' offices to get your medications right, the pharmacies and to get them right, good research says that only 16% of electronic medical records are right. So the only way to know if you're right is that we check and you check. So during this pandemic, I've now taken on the task of reviewing medications on every visit. You come for prescription renewals, we're going to check again. And frankly, you should never have the pharmacist calling for a prescription renewal. You don't call the tow truck when you have a flat tire unless it's an emergency. So why do you do that about your medications? There'll be back orders on medications. There'll be trouble getting access to this thing. So I urge you to take a bigger stand in your health. Thousands of people die every year from medical errors, and you have to decide if you want to be a medical error or if you're going to make steps to become one. Because if you backtrack one slide, this is a team. The Toronto Raptors took decades to become a championship team. It wasn't one player; it was a combination of all the above. So if you have congestive heart failure, we need to put a team approach to help you. And medications are so valuable in this circumstance. If you're not on medications, unfortunately, your life will end before its time. Anything else you want to add to that, Monica?
No, I really support that as well. Being a medical error is you don't want to end up like that, and it's just takes 5 or 10 extra minutes to update your medication list, or just to take that time to write it down and always have it on you, whether it's on your phone as a picture or on a piece of paper. I fully agree with you, Doctor. It's well said.
And if you had trouble with it, have somebody else help you with it, and make it a team sport. And it's okay. None of us are perfect. And we need to work to get better. Next slide, please. Sick day medications. So these medications are phenomenal, but if you're not feeling well, you need to stop certain things, because if your blood pressure gets too low, your potassium gets too high, your kidney function gets too bad. We're not going to talk about this today, but take a picture of this and learn to adjust your medication. So you're having diarrhea, you're nauseated, vomiting, you have to stop some medications. And this is something you should, it's called SADMANS. Learn about it. It's in our webinars. Now, Monica and her team has put together a lot of webinars. Jenny's made up a lot of webinars on diabetes, so take the time to understand this. Next slide, please. Again, this is actually from the Diabetes Canada. It should be in congestive heart failure. And anything you want to add to that, Monica? This is something you should print out. Go to Diabetes Canada and print it out and just look at that. Just follow directions and then talk to your team about that.
Yeah, you're reading my mind and more, Doctor, so it's good. So we can move on to the next topic of management, and that's health awareness. So I think Aditi can take it away here.
Yes, just give me 1 second. Okay, so next we're going to talk about health awareness with CHF. So the first thing I'm going to talk about is the CHF checklist. So this is just some things that you should run through on a daily basis just to keep track of your health, how you're feeling, and it'll help you notice any changes within your health, within your body, and keeping track of these sorts of metrics allows you to really tell your doctor when things might be changing, when things might be going different, and also for you to have just some personal awareness about it and make those appropriate adjustments within your life. So one thing to note is your weight. So how much are you weighing today? We've talked a little bit about weight being a risk factor for developing various conditions, and I will be talking a little bit about BMI in the slides to come. So just making sure you keep track of your weight. Any changes from yesterday, so changes in weight, changes in how you're feeling, maybe even changes in your blood pressure, your heart rate, things like that to note. Then making sure you take your blood pressure. Blood pressure is really important, and I'll be covering that in a couple of slides as well as to how to read your blood pressure machine and why it's so important, but just making sure you take note of that every day if possible. And then a couple of other things. So did I drink 6 to 8 glasses of water today? So in CHF, we're concerned with fluid overload. So 8 glasses is usually the cap for the amount that you should be consuming. But consuming water is nonetheless important. It's important for you to remain hydrated. It helps maintain ion concentrations in your body. So making sure that you drink water, but you're not going overboard with drinking water. Then, have I taken my medication as directed by my doctor? So it's extremely important to keep track of all of the medications you're taking, and making sure that you're taking them regularly on a daily basis. Am I free of swelling in my feet, ankles, legs, or stomach? So as I mentioned with CHF, we're concerned with fluid overload, and how you notice fluid overload is swelling in your extremities or in your stomach, so keeping an eye on that. If you notice that the swelling is getting worse, that's definitely something to bring up in a conversation with your physician. Am I eating foods that are low in salt or salt-free? So if you eat a lot of salt or salty food, it not only increases your blood pressure, but it also causes you to retain more fluid. So that's, again, something to keep track of. If you're starting to have a lot of swelling in your extremities, think about the types of foods you're eating and see if there's a potential to cut out some salt in your diet and see if that might make a difference for you. And then, have I been balancing activity and rest periods? So remaining active is important, but it's also important to give your body time to heal, so just making sure you keep a balance of that in your day. So moving beyond that checklist, then you can kind of establish what zone you feel you're in. So if everything is fine, you're feeling all good, then you're in the green zone, all good. That's where we want you to be. That's kind of an indication that you're doing okay, you're managing your condition well. Yellow is progressive, so there might be some things wrong, there might be some things you need to figure out. This is maybe when you might want to make an appointment with your physician to discuss what you should be doing differently or why you might be experiencing these changes. And red is an emergency. So this usually means you need some sort of immediate intervention. You might have to address this problem right away. So keeping this checklist in mind and going through it every day can help ensure that you stay in the green zone as much as possible, and that you notice when you're starting to progress to these other zones so you can take action quickly. So moving on to weight. If you don't have a scale already at home, highly recommended that you get one. It helps you keep track of your body weight. And a measurement that's commonly used when we talk about body weight is the body mass index. So basically how you calculate that is your weight over your height squared. And that's for kilograms and meters, and then I have the calculation up for pounds and inches as well. And the simplest way to do it is to just go online BMI calculator. The first link that pops up is from the National Institute of Health. So you can just kind of input all of your metrics and it'll give you what your BMI is, as well as a listing of what's considered to be a healthy BMI versus underweight, overweight, or obese. So this image I have is from the CDC, and basically you want your BMI to be between 18.5 to 24.9 or 25. Between 25 to 29, you're considered overweight, but if you're able to keep it stable in that region, that's okay. As always, try to work to getting it lower, but within that region is not too bad. If you're at a BMI of 30 or over, that's considered obese, and this can just make dealing with congestive heart failure much harder. It can also put you at risk for a variety of other conditions. So the recommendation is to try and stay like below 30 in BMI, around 27 if you're able to. So it's hard to kind of predict what your BMI is going to be or where you fall on this weight range if you don't have a scale at home. So if that's something you're able to do, if you don't already have a scale, consider investing in one because it'll help you keep track of your weight. And moving on to blood pressure. So like a scale, if you don't have a blood pressure machine, consider investing in one. They can be on the more expensive side. They do fall in the range of $75 to $100. So that is definitely a concern for some people, but consider investing in it if you're able to. It is an investment. So in terms of reading your blood pressure, there's two numbers. So there's your systolic blood pressure. This is your pressure when your heart contracts, and your diastolic, which is the relaxation. So that'll be the smaller number. And a blood pressure machine will also tell you your pulse. So when we talk about the ranges for blood pressure, usually 120 over 80 is what you want to be aiming for. That's considered normal. So in and around that measurement's pretty good. And then elevated is 120 to 130. So you would ideally want it lower, but you're not in a ton of danger in this stage. 130 to like your 140s, again, elevated, not a huge concern, but you ideally don't want it to be in this area. And then above 140, that's something that you need to tell your doctor about, especially if you're on blood pressure medications and you're still consistently having those high readings. That's something to make note of because it can significantly increase your risk for progressing with your CHF or developing other conditions. And if your blood pressure does drop, so if you're noticing that you're experiencing symptoms, lightheadedness, dizziness, and your blood pressure tends to be lower when you experience the symptoms, like 90 to 100 systolic, lower than 90 systolic. This is, again, something you have to tell your doctor. And the goal for heart rate for people with CHF, as Dr. Kearney mentioned, is about 60 beats per minute. If you do have atrial fibrillation, it can be a little bit higher. And another thing is that your blood pressure machine sometimes notices when you have irregular heart rhythms, especially if you have the ones that have like that dictation where they tell you how to take the blood pressure. It will tell you if there is an irregular heart rate. So that's another thing you can do with the blood pressure machine, is notice when you might have those irregular heartbeats.
That's wonderful. What I find that when people actually measure their blood pressure, you want to measure it multiple times. We have multiple webinars, how to measure blood pressure, learn how to do it, learn the correct position. You know, when you're angry, upset, you're running around, your blood pressure should go up. That's normal. That's not hypertension. And if you feel dizzy when you get up, well, measure your blood pressure when you're getting up. You know, if your blood pressure is at, let's say is 120/80 sitting, and you stand up, it goes down to 90 and you feel dizzy, write that down and let me know about that. We have to make some changes about that because blood pressure should change. If your blood pressure is always the same couple things, either you're not measuring it properly or you're dead, because blood pressure has to move and vary. Lack of blood pressure variability is a bad sign. So I'm actually quite ecstatic when someone, is rushing around, the blood pressure goes up to 180, or you're upset, it goes up. That's good. But if it's consistently elevated when you're sitting relaxed, that's bad. You need to learn that. You need to know your pulse. Now, some of these machines do a better job at others looking at regular heartbeats. So if you think your heartbeat's irregular, jot that down. We can actually do a proper Holter monitor if we need to, or an ECG if we need to. And you can actually now get devices such as a cardiac device and such as the Apple Watch, other technology to look at that. Fitbit and others just gives you the actual heartbeat. It doesn't tell you what the rhythm strip is. So if you ever get a monitor that tells you what the strip is, make sure you can print it and bring it to me on your next appointment so we can look at that. So thank you for sharing that. And you always want to get a machine that's approved by Hypertension Canada.
And just briefly before I talk about atrial fibrillation, you want to measure your blood pressure pretty regularly at home. So if you're not taking it every day, every couple of days, ideally every day would be great. When we see you in the clinic and we take your blood pressure, that's one visit. We don't know if that represents your blood pressure across your daily life, your everyday experiences. And there are cases of like white coat where your blood pressure is significantly higher in the clinic, but there can also be the reverse where your blood pressure might be higher at home but normal in the clinical setting. So just making sure that you're taking your blood pressure consistently, because you taking your blood pressure consistently are more likely to notice the changes that are happening than we would be on taking it at one occasion at the clinic. So just something to keep in mind in taking blood pressure. And then on to atrial fibrillation. So this is an irregular heartbeat. It's a type of arrhythmia. And atrial fibrillation can increase the risk for stroke, heart failure, and other cardiac complications. So atrial fibrillation and congestive heart failure, CHF, are comorbidities. From the Framingham Heart Study, it showed that patients who had atrial fibrillation are at higher risk for getting CHF, and vice versa. Patients with CHF are at a higher risk for getting atrial fibrillation. And atrial fibrillation does have a bunch of lifestyle factors factors and other components and risk factors that you can kind of take care of and modulate to reduce your symptoms or reduce your risk for developing it. So one is alcohol and tobacco usage, which increases the risk for atrial fibrillation and can also exacerbate atrial fibrillation if you already have it. So the recommendation is to limit the drinking, which is about 14 grams of alcohol per day. The aim is to actually completely abstain from drinking alcohol if possible, but starting on reduction is the first step towards completely abstaining. And for smoking, it's best to completely abstain from smoking or utilizing tobacco products. Next is sleep apnea. So if you have sleep apnea, make sure that it gets treated. So moderate to severe obstructive sleep apnea can be treated with a CPAP machine. Sleep apnea is also associated with being overweight. So sometimes losing that weight can help also improve this condition to the point where it's not quite as severe. Next, there is weight loss. So weight increases the risk for many conditions. It just places a greater burden on your system and your body. Your heart has to work that much harder when the more weight that you have on you. So weight loss can help take some of that burden off your system. And weight loss can also increase your risk for other conditions. One of them is sleep apnea. So reducing your weight can help you manage atrial fibrillation or lower your risk for developing it. And the target for weight loss is about 10% of your BMI. You want to lose that. So you want to get to about 27 or under. That would be ideal. Then there is diabetes, which was talked about earlier. So manage your diabetes. So at the clinic, when we look at your blood work, we look at your HbA1c value, which is your 3-month average for your glucose readings. So if you have diabetes, you want this to be less than 7 or around 7. That kind of indicates that you're able to manage your blood sugars okay. Then there's exercise, so moderate intensity aerobic exercise for about 30 minutes a day, at least 3 to 5 times a week, adding in some resistance about 2 to 3 times a week, and working on flexibility around 2 days a week. Increasing your physical activity can also not only helps with weight loss, it also helps condition your system, which can reduce your risk or reduce the exacerbation of atrial fibrillation. And finally, there's blood pressure. So you want it to be less than 130/80 systolic and diastolic at rest, and less than 200/100 during peak performance. So that's kind of like the tip when you're talking about exercising and like vigorous exercise. You don't want to get it to exceed that point. And take your blood pressure medications. That's really important. Make sure you're taking note of when you take your blood pressure in relation to when you take your blood pressure medications. If you take your blood pressure before you take your blood pressure medications, it might be much higher because it's not being controlled by the medications at that point. And then losing weight can also help maintain your blood pressure in a desirable range.
Okay. Yeah, thank you, Adi. Those are really important points for management. Blood pressure, weight, and so blood work we've already talked a bit about with BNP, and we talked about potassium and hemoglobin. We're going to just highlight the kidney function here because congestive heart failure leads to poor pumping efficiency and causes a buildup of blood in your veins, which can lead to congestion of blood in your kidneys as well. So some creatinine levels to look out for, as well as eGFR levels. So elevated creatinine can, normal is usually between 50 to 120. And then for eGFR, less than 60 is a decreased level, and that can also vary with other conditions. But yeah, it's just important to highlight that there's a relationship between heart failure and your other organs as well, and kidney being an important one as well.
So your kidney is a very vascular organ. It varies by age. So so I was thinking about a creatinine should be less than 100, and a GFR should be above 90 for most people. But as I get older, if you're 85 years of age and you have a GFR of 60, that's phenomenal. That's pretty good. If your GFR, if you're 60 and you're 25, that's a problem. So there's ways of looking at that, and so again, when your kidneys don't work, nothing else works too as well. So and really, once you have kidney damage, there's not much you can really do about it. If it's really bad, you go for dialysis or transplantation, but you need to preserve your kidney function, and we have very effective medications to do that. So if you smoke, have control your blood pressure, control your weight. We have ACE-ARB therapy, and now SGLT receptor antagonists are valuable to protect your kidneys.
So we'll get into exercise as well. Dr. Kearney, how were the stairs this morning?
Good. I got there late like usual, but I was able to do 5 sets today, and I'm trying to think right now, am I going to go do any more sets tonight or not? I'm not quite sure. But plan to go biking this weekend. Hope maybe maybe even some outdoor tennis somewhere is a possibility. But we'll see. So keep exercising, everybody. Find some activity.
And the weather has been helpful. I just went for a walk before we started the webinar. Got a bit of fresh air. So so for exercise, we need to form good habits. Didi, did you want to?
Yes, I can take it from you.
Thank you.
Okay. So the Canadian Physical Activity Guidelines recommend about 150 minutes of moderate to vigorous intensity aerobic physical activity per week. So you can do this in bouts of 10 minutes or more. You don't actually have to do all 150 minutes in one day. You can split it up over your week however you would like. So some of the benefits of aerobic physical activity include that it improving your circulation, which helps with better oxygenation of your body. It improves COPD symptoms. So exercise can be hard for people with COPD because the shortness of breath can really limit the amount that you're able to do, which is why it's great to break it up into small little chunks that are manageable, and over time you'll be able to do more and more. It also strengthens your heart and cardiovascular system, reducing the development of chronic diseases, and it helps maintain bone health. Another important point for bone health, especially in women past menopause, a concern is osteoporosis. So in addition to aerobic activity, you do need to incorporate some strength and resistance training. You should do this in general to help maintain your body, but it's extremely important in maintaining bone health. Our bones respond to the pressures that we put on the body, so conditioning them to those conditions will help prevent them from breaking down and wearing. And lastly, aerobic activity will improve your muscle tone and strength, and this can also help reduce body fat. So it'll ultimately help with some weight loss as well. So examples include brisk walking, cycling, swimming, hiking, and it's also recommended that you add some muscle and bone strengthening activities using major muscle groups, and try to do this at least 2 days per week. So one way you can test your functional capacity is the 6-minute walk test. So basically this is just the distance you walk over 6 minutes. So you set a stopwatch or a timer for 6 minutes, and then you see how much you can walk. So it's a measurement of your functional capacity, and it can also test your response to treatments, especially for heart failure. So we want to make sure that the treatments are working. We want to assess what stage you're at, and this is something you can do for yourself, is the 6-minute walk test, to kind of test where you're at. So a significant predictor of mortality for heart failure is the 6-minute walk test, and we can look at your performance and see what that means in terms of your heart failure. So if you're not able to walk more than 300 meters during the 6 minutes, that predicts poor outcomes for patients with heart failure. And if you're performing the 6-minute walk test and you start to feel tired or fatigued, you can rest, but you can't stop the timer. So if you're able to walk for a little bit and you do need to take a break, you can definitely do that, but don't stop the timer, because we want to see ultimately how far can you get in 6 minutes. And in terms of exercising, we do have a new group that meets on Wednesday evenings, the Mindfulness, Motivation, and Exercise group. So if you're kind of looking to get started and you're not sure where to start, signing up for that group might be a great idea. There's some fantastic volunteers who are involved with it and who lead it and can really ease you into this process.
So what I'm going to encourage everybody to do is to do a 6-minute walk test and send in your steps. So what we'll do is we'll have the draw. So for those who send in their 6-minute walk test, we'll email to drkernu@232gmail.com. Put your name, your date of birth, and how many steps you can do in 6 minutes. How distance. If you want to do steps, that's fine too. Use your step counter. If you want to do stairs, that's fine too as well. I think my next time I'm going to see how many stairs I can do in 6 minutes. So And do it often, do it fun. So just try to do it once a month and just see how you can get more fit.
And so next we'll talk about diet. So healthy eating. The image we have is from the Canada Food Guide, and this is how they recommend you make up your plate for every meal. So you want half of it to be fruits and vegetables, and then a quarter can be protein foods. Our recommendation is that you try and make the proteins more plant-based if possible, and I'll be talking about plant-based eating in the next slide. For proteins, a lot of people tend to eat meat for the protein. Just try to stick to leaner meats with less fat content, as that can kind of help reduce the amount of calories and the amount of fat you're consuming with your protein foods. Then the next part is grains, so trying to choose whole grains. So carbohydrate components of your diet, if they're things like white bread or white pasta, trying to replace those with the whole grain versions. They add more fiber, and it's less it's more of a complex carb that you're consuming, so it's not releasing that much sugar into your system at like that same rate. And then for your drink of choice, that should be water. Drinking things, there's a lot of things about like juice diets and smoothies and all sorts of things. Water is still the best option. A lot of the things that you put in like juices and smoothies, while vegetables and fruits do have a lot of vitamins and minerals, the other big component of them is fiber, which is really good for your system. And you tend to lose some of that when you make juices or you make smoothies. So while you can have those in moderation in your diet, try to make water your drink of choice as often as possible. And another thing we wanted to talk about is just avoiding processed foods, which are high in sodium and fats and cholesterol. So a great way to do this is start cooking at home, start making your meals more homemade. That cuts down on the amount of processed things and additives that are added to the food. Plus, you know exactly what's going into your meal. You know how much you're putting in and what you're putting in, and that can really help control your diet. And lastly, we just want to mention mindful eating. So when we talk about going on a diet, whether that's making like a diet change or a diet change to lose weight, we can often tend to see food as the enemy, thinking about things we need to kick out of our diet, things we need to eliminate, and that can give you a really negative relationship with food. And there is a concern there that can lead to things like disordered eating. So just remembering why you're eating food and making sure you're choosing the right types of food. So eating food is a way to nourish your body, and that only works if you choose good nutrient-rich food. So eat slowly without distraction and learn to identify your hunger cues. So in a situation where you find yourself hungry, try to ask yourself why you're hungry. It's definitely been like a struggle with being at home so often in COVID and with the stay-at-home order and everything. People just tend to snack because they're bored and the food is right there. So trying to identify those cues and understanding when you're hungry and how you can satisfy your hunger cravings. And you should make sure that you're picking the right kinds of food and you feel good about eating the healthy foods. And that can also help encourage you to try new things. So if there's a vegetable that I don't particularly like, maybe I can think about the nutritional benefits of it and try to think about how good I'll feel after I eat that. And it'll make me more likely to try this new type of vegetable and more likely to incorporate that in my diet. And then focus on eating for its benefits. So I'm eating healthy because it'll help my body feel better and it'll improve my health. So that way food's not really the enemy, but it's a way to give your body the fuel it needs.
One thing I should mention is that actually, go ahead. Dee's going to talk about. Are you going to talk about your program that you're putting on?
I was going to mention it at the end.
Perfect.
Okay.
It's wonderful. I love it.
So now on to plant-based eating. So plant-based eating is really beneficial for the environment, but it's also really good for your body. So the BROAD trial was a randomized control trial that looked at people on a plant-based diet, and it found that plant-based diets can help you reduce your BMI, your cholesterol, and your HbA1c, so all things we're concerned about at the clinic. And it was able to do this at the 3-month mark of being on a plant-based diet. So when you ask yourself, how can you go plant-based? The simplest way is to try and replace your protein sources with plant-based products. And for this, we're not talking about like Beyond Meat or imitation meat. Those can be very heavily processed. They're not really adding a lot of nutritional value, so trying to go for the more natural plant-based foods. So this includes things like legumes, so beans and lentils, nuts and seeds. Again, nuts and seeds in moderation, they are quite high in calories, so making sure that you're having like only a handful and making sure you are aware of the amounts that you're having in your diet. And other things include quinoa and oatmeal. These are great grains that you can put onto your plate. Oatmeal is a fantastic breakfast, high in fiber, high in protein. And another thing is tofu. That's another type of plant-based protein that you can introduce into your diet. So this image here just kind of shows the different types of plant-based proteins, things like nut butter, some whole grains, legumes, beans, and each thing will have like a different amount of protein, carbs, and fibers. So that's something, there are lots of different helpful charts online. So if you're ever wondering like what kind of bean is going to give me the most protein and like the most fiber but is on the lower end in terms of its carbohydrate content, just Google it and you'll find all of the information you need and can make your choices that way. And in terms of plant-based eating, we are starting a new workshop. We actually had our first session last weekend on Sunday. We'll be talking kind of about cooking and plant-based eating and talking about the nutrients, but also doing the cooking over Zoom. So if you're new to this type of diet or you're new to cooking at home and that's something you're interested in, please let us know. We'll be happy to include you in our future sessions.
And that was a wonderful session. I really enjoyed it.
And finally, on to calorie restriction. So if you are dieting to lose weight, if you're not exercising that intensely, you do need to be in a bit of a calorie deficit in order to lose weight. So as I've mentioned earlier, losing weight is an important part of CHF management and also reducing the risk for developing further complications. So with diet, that involves calorie restriction. That usually just means reducing your calorie intake below what is typical for you on a natural day. So you can kind of think about it as eating less than what you're burning. Typically, the recommendation is around like 1,000 to like 1,600 if you're pretty active. That's where you would want to stay. The less active you are, the more you might have to restrict your calories. And calorie restriction can induce weight loss in overweight and obese patients. There are other types of benefits as well. So it can preserve cognition, delay osteoporosis, and all of that. But the main goal we want you to focus on is that it can help with weight loss. So reducing the amount of calories within your day can help with that. And some tips on how to properly do that is about thinking about including foods in your diet that can keep you full for longer. So thinking about having complex carbs, stuff like that. So a great complex carb you can include in your meals in moderation is sweet potatoes. It tends to add a little more heft to a veggie meal and keeps you fuller for longer, so you're able to kind of achieve those calorie restriction goals.
So now we're going to get into palliative care, and we have just a few brief slides on just to open the conversation and the discussion about it. And just always know that's a topic you can bring up with Dr. Kernew. It's an important topic to have with family and friends. So Nicholas, if you could take it away for us here.
Yeah, thank you. So while there is no cure for congestive heart failure, unfortunately, there are some things you can try to do to manage it. So you try talking to your doctor about taking the appropriate medications to control your blood pressure. Additionally, you also want to build healthy habits, which is something we've talked about a lot. So exercise and diet, as mentioned, are quite huge, as well as alcohol reduction, which Dr. Kernew always talks about being a type 1 carcinogen. And then, of course, as mentioned as well, quitting smoking would be ideal. You can also talk to Dr. Kernew or your other doctors about discussing alternative surgeries to determine the best course of action for you. And if you have been hospitalized or hospitalized multiple times, you might want to consider what your end goals are. And this can include the question of living in a hospital versus home, as well as the discussion of MAID, which is medical assistance in dying. So you may need to discuss palliative care and what you want your future to look like. Dr. Kearney, do you have anything else to add to this slide?
It's one of those areas that we don't always make our wishes known. And things to remember is that at some point in time, we are going to leave this planet, and how we end our lives have a great impact on others. And I can just say from personal experiences that once you open the conversation, it makes things easier for some people. Some people want everything done in all circumstances. Very few want that. People want quality of life at this stage. And don't be afraid to talk about that. And don't be afraid to talk to family members about that. And we're going to have more discussions about that. We just talked about the nursing home situation, and we're going to come back at how to age properly. All I can say from my personal experience is that both my parents died of dementing illnesses. My mother's death was a scar to many of our family members. My father's passing away was a joy and celebration of his life. And I want people to decide what's right for them and have discussions. Many of us, or 90% of us, want to die at home if we can. Very hard to die at home, but resources can be put into place. And we're now making that very important consideration. So heart failure has a very episodic, unpredictable course, but it does have a progressive downward course for many people. And having your hip operation done when your life expectancy is months makes no sense to me. Having operations that will not be helpful are something to think about. So that's a very personal discussion, and I think most family members want to hear what you have to say. And when you represent somebody, represent them, not what you want, is what they want. So thank you for bringing that up, and we should have lots of discussions about that. And please look at the video we did on what's happening in our nursing home situation, and please look at the future and how to retire well and how to be more proactive in one's health. So thank you for bringing that up. Next slide, please.
Yeah, so although most people under hospice care tend to remain in their own homes, the program is available anywhere, including nursing homes and assisted living centers. And so for people who stay in a hospital or one of these long-term care places, specialists in end-of-life care can provide comfort, compassionate care, and a sense of dignity. And although it can be difficult, please discuss end-of-life issues with your family and medical team. Part of this discussion will likely involve advanced directives, which is a general term for oral and written instructions that you give concerning your medical care should you become unable to speak for yourself. If you have an implantable cardioverter defibrillator, so ICD, one important consideration to discuss with your family and doctors is turning off the defibrillator so that it can't deliver shocks to have your heart continue to beat. So yeah, this is quite a difficult. It's quite a difficult discussion to have, and so communication is quite key here. And this is something you could always bring up with Dr. Kearney.
Thank you.
So now sorry, Dr. Kearney, go ahead.
Go ahead.
All right, so we're going to be jumping into some of the research and trials surrounding congestive heart failure now. So starting off with the EMPEROR study. So I know Dr. Kearney talks about this a lot in the clinic. I always hear this get thrown around. So the EMPEROR study involves 2 clinical research studies that investigate the safety and effectiveness of Jardiance in more than 6,000 people with congestive heart failure with preserved or reduced ejection fraction. And so the patients were randomly assigned to receive either Jardiance or placebo. So this is a randomized controlled trial, which is the highest level of clinical evidence. And over the 3-year participation period, the main outcome investigated is cardiovascular death or hospitalization. So now Jardiance, which is also known as an SGLT2 receptor antagonist, is currently approved for type 2 diabetes, and it decreases the amount of sugar in the body by increasing the amount of glucose that gets passed in the urine. So this study is quite large and spans 36 sites in Canada, and in terms of international reach, it expands beyond Canada to reach 564 sites globally. So it's quite large.
Yeah, and Dr. Kearney's clinic is one of the sites in Canada.
And so we mentioned that Jardiance is approved for type 2 diabetes, but sir, how is that relevant to congestive heart failure? Well, patients with diabetes are much more likely to develop congestive heart failure than patients without diabetes. Hence why SGLT inhibitors were explored as a pharmacological intervention. So here we have a flow chart that depicts the rationale for why this drug was investigated. Now, Dr. Kearney, do you have anything to add to the?
So if you just backtrack, this drug was actually developed for diabetes, and they found out by accident it protects from heart failure. So it's been proven in patients who have reduced ejection fraction. We're just wrapping up the preserved ejection fraction. That result will be available at the European Cardiology meeting in late August, early September. So it's a remarkable journey. So that's where actually part of our learn to use pro-BNP and BNP better, because we learned to that. Next slide, please. So it's a wonderful category medication. Research tells research and it expands. Next slide, please. The other thing that we learned, next slide, is that in DAPA heart failure, this is actually a different SGLT receptor antagonist. Forxiga is the trade name. And that, again, was developed in diabetes, but it's been discovered to be protective in heart failure, in diabetes, outside of diabetes as well. Same thing with Jardiance as well. And more importantly, also protect kidneys. Next slide, please. So we've made tremendous inroads, and we have a whole webinar on that. So we have, this is a remarkable category of medication. So we have very few drugs that actually protect the kidney. This is one of them. We have drugs like spironolactone protects the kidneys, and we have drugs like ACE inhibition or ARB protects the kidneys. But this actually has the best protection against the deterioration of kidney function. Next slide, please. So you can see how my rules expanded. And this is a complicated slide saying that the kidney function initially gets worse before it gets better. Let me deal with that, and let me help you. And don't change your drugs without talking to people who know what they're talking about. Next slide, please. But remarkable progress, remarkable journey. And we still have a lot more to learn about this. So this came as a total surprise. But wow, we now have a way of managing diabetes beyond diabetes, protecting kidneys and protecting the heart. Next slide, please. Now, we're also trying to find different ways to learn and things of that nature. And Monica and her team is working on an app development for our clinic. So I'll let Monica talk a little bit about that and her team. Are you talking about that, Monica, or is somebody else going to?
Yes. Yeah. So yeah, Dr. Kearney's clinic, as you can see, he's always making initiatives, getting involved with the community and everything, and he gave us the opportunity to try to develop an app that would actually help patients in the clinic. So here's a little sneak peek or a teaser. We're working hard behind the scenes, learning how to create an app. But essentially, we're hoping that this app will be a useful tool for you. We already did send out the first round of surveys to get preliminary feedback from the patients at the clinic, and we found that the appointment reminders, medication lists are very helpful. We're also going to include the clinic resources and have a collaborative community on the app. So focus groups and workshops will also all be accessible on your phone. So just like we have all the other apps, this will be, we're hoping it will be a great app for you to have. so you can store your medications and make your life a bit easier to help with your visits to the clinic as well as in your daily routine. So the daily reminders to measure blood pressure, weight, your heart rate, and things like that. And then this is kind of the layout we're working with at the moment. Wish us the best as we continue to move forward with it, but we're very excited to hopefully release it maybe sometime this year, you know? It's a work in progress, but we're getting there, and it's exciting to learn how to create something new. So it's a journey.
Just keep learning, and one way to prevent Alzheimer's disease is to develop new skills. So we'll see what we can do about that, and collaboration is always key to success. So we'll see how that comes out. So this is not ready yet, but we're working on it. Next slide, please. Thank you, Monica, for spearheading this.
Thank you.
Rehabilitation. So there's cardiac rehab for people at the Hamilton General Hospital Health Sciences who've had a heart attack. This is their site. A lot of things are virtual at this point in time. It's struggling during the pandemic, and we hope in the future that they'll be up and running again, non-virtually. And that actually spearheaded us. Who I thought that Friday night I'd be talking to you, and I keep saying I try to make these short, but there's so much to say. And next slide, please. So we'll think about different ways of doing things. Did you want to say something about the North End Community Center at all?
They were doing the 10-week program for the community, but again, with COVID, I'm not sure. But I think we just kept these in to remind patients that there's lots of resources to help them on their journeys, and they don't have to do it alone, and they have peer support groups and such, and in the clinic we have so many webinars and groups as well, so lots of support to reach your goals.
So their expertise is at the Center for Smoking Cessation. They're doing things virtually at this point in time. Public health is working in that area. Obviously, public health's big priority right now is getting the COVID vaccine out. So lots of wonderful resources. And I have to thank Winnie from our team, who's had a series of webinars. And she just put out another one about 2 weeks ago that looks about your journey about tobacco and ways of looking at that, starting with nicotine replacement and other therapies as well. And she'll also call you up and talk about things. She does it in such a caring way. So remember, every time you smoke, 5 minutes of life is gone. Right now is that every moment is precious, as well as quality of quantity of life. So nothing good about smoking. Very hard to get rid of the habit and the chemical addiction. There's so much you can do to get better. So take advantage of those resources. Next slide, please. And this is actually, this is the STOP program as well. There's the tobacco hotline. Public health is involved in this right now, and see if you're eligible to get support for nicotine replacement therapy or not. Many family health teams have that available to you. You can get it at the pharmacy as well on your own. You can get these non-prescription nicotine replacement therapy. Many drug plans don't cover it. The government doesn't cover it either at this point in time. I feel sorry for the government. It has so many priorities. When I hear how big the debt is right now, we have to do something about that as well. My hope is that when I leave this planet, the national debt goes away, and I don't think our generation should leave the debt to the next layer of people. I think we've done a bad job of that. So I'm going to be as healthy for as long as I can and try to make contributions as best I can. So one of the things is, if you smoke, stop. If you don't want to stop smoking, think about why and try to get better at that. You can. It takes 6 or 7 times most of the time, but you can do it.
And that brings us to the end. So,
and this is actually kind of funny. Is that this is the newest member of the family. There's Tigger, my daughter's cat, and this over there is Ticker. We have three baby goats right now, so having animals around is wonderful. I'm always on my computer, and my new friend, the goat, Ticker here, Ticker for the heart, is learning how to become healthier as well. And Next slide, please. And my wife had that double trouble. And I want you to explore some other things. Next slide, please, if you may.
This is the last one here.
I think we do have another slide. I think we have what.
The iron slides?
Yeah.
I think it didn't update. Sorry, one second.
That's okay. We'll hit it. So basically, just to summarize, congestive heart failure is a disease that the heart can't pump properly. It does at a higher filling pressure. We can make the diagnosis: you're short of breath, you're fatigued. You know, is that we can go back to the congestive heart failure part. We've gone long about this. I want to just say to people is that we can prevent congestive heart failure. We can treat it better. We're going to look at better ways of doing this. One of the things we'll talk in the future about is that new therapies such as iron therapy that's changed dramatically. So there's still much to learn about this. I talk more than I want to at this point in time, so I think we're good about that. I think we'll end over here, but before we end, if we can just backtrack that slide there. Are there any questions at all from people at all? Stuart, any comments from people?
We had a question that was asked earlier. You addressed it, but I can ask it one more time. We did have a viewer ask, should you get the BNP test at least once? How often should you get it? Is it just on recommendations from your doctor, or should you seek it out yourself?
Yeah. So BNP needs to be interpreted into context. It goes up in heart failure, but it can also go up in other disease processes such as pulmonary embolism too as well, across the lungs. So that's a test that you have to decide with the help of people like myself and other doctors. So it does cost $75. So I don't want to spend your money unless it needs to be spent. It can add value to your care. If $75, the first thing I would do is buy a blood pressure machine, and a scale is my number one priority. In circumstances where we're confused, we need to know more. It's a very valuable test. It gives lots of insight. But it's not necessary for lots of people. In many cases, it's game-changing. So there are times where we got the diagnosis wrong, and BNP can actually change our pro-BNP. So very useful. I just think it's a new tool that we're learning to use better, and having experience using it for over 5 years right now, I think I can use it better. I'm still learning how to use it well. Still lots to learn. The best way to treat heart failure is to prevent it from happening in the first place. So I hope that came across loud and clear that you can actually, in many circumstances, delay it and treat it more effectively. It doesn't have to be as a scary diagnosis, but it is unpredictable as well. You just want to stack the odds in your favor. Any other comments at all from anybody?
Looking on the YouTube, we don't have any, but I have one question actually that I wanted to ask. We talked about echoes earlier. We know blood pressure fluctuates throughout the day, and you recommend taking it at home. When it comes to an echo, and when it comes to ejection fractions, is that something that fluctuates regularly, or is that something that's pretty consistent throughout? And my second question then is, if your ejection fraction is below 55, what are the chances of getting it back up to 55? Is it possible?
Yeah. So the first question is that blood pressure is really important. When we actually do an echo, we need to know the heartbeat, the rhythm of the heart, and the blood pressure. So you can imagine is that if you have a weak heart and your heartbeat's going 110 beats per minute and your blood pressure is 200, the ejection fraction will be low. If you control the blood pressure, you control the heartbeat, the ejection fraction will improve. So yeah, it's very important. So part of every echo study, you need to know the person's weight, the height, the blood pressure, and the heartbeat, and the rhythm. Very, very important. It changes dramatically. Yes, and we demonstrated that mortality can be reduced from about 35% at 2 years to about 10% at 2 years, and with improvement of ejection fraction as well. And if your ejection fraction improved, you need to maintain the medications that made it stronger, because it wants to happen again. There's actually trials of withdrawing medications and the ejection fraction can worsen. The other time to think about is if your heartbeat's going too fast, we control the heartbeat, control the rhythm. If you drink alcohol or you had a virus of the heart that's been treated, in some of those circumstances, maybe you can actually reduce or stop certain medications, but it's very much an individual decision. So I'm pleased to say that if you have a low ejection fraction, it's a rule of three. A third will get better, a third will stay the same, and a third will get worse. And you can decide what category you want to stack the odds in your favor. So lots to do about that. And that's their kicker or Goat or myself are trying to study how to make everybody's heart stronger. What I did notice today is that I only have about 7,800 steps. I didn't get my 10,000 steps, so I have to go for another walk one more time tonight to get to that 10,000 steps to maintain that effect there. Any other thoughts at all? Well, I just want to thank everybody. This is a lot of work for a lot of people, and I thank you all. I want to thank people for spending the time to listen to this webinar. I want people to encourage you to go back out to the other webinars because they're all helpful. Pause, look at that. Think about what you can do to prevent heart failure, and once you have it, how we can treat it better. So thank you all for attending. And I bid everybody good night. Stuart, I'll just give you the last word.
Well, I couldn't add any more than what's already been said. Speakers, your expertise on the topic today was commendable. Very, very in-depth conversation. I was taking pictures actually throughout because I want to go back to it. And just as a reminder to everyone who's joining us right now, you're always more than welcome to rewatch the video, pause it, go back, fast forward, do it at 2 times speed, whatever's most comfortable for you. These videos are going to stay up on YouTube forever, so this information is not going to be lost. So there's no excuse to forget it. You can watch it 5 times, and 20% you remember. So if you watch it 5 times, it'll add up to 100. You'll remember everything we said. So watch it 5 times.
Good night, everybody. We'll see you next week. And I thank everybody for participating, and look forward to being healthy.
Good night, everyone.